So the case is about a 21 years old female patient with normal size. She's 68 kilograms. She had a diagnosis of perimembranous VSD when she was 2 years old. Then she had the regular follow-up, and the evolution was on left ventricle overload. The clinical examination, this patient is NYHA1 class, even though she doesn't.
Ensuite, suprasternal pour qu'on monte le.
Regular exercise. She had a systolic murmur, and the rest of the exam is normal. Here we have the electrocardiogram that we can see that the AV conduction is normal. Here we see the left ventricle function that is normal. We can see a moderate dilatation of the left ventricle with a small mitral valve regurgitation. Here we can see the perimembranous VSD with left to right restrictive shunt. Here, once again, we can see the left to right shunt, and we can see the proximity with the aortic valve. In short axis, we can have a better idea of the size of this VSD. And once again, we see the proximity with the right coronary leaf left. More or less, the evaluation of the size of this VSD was about 3.5 millimeters on the left side and a bit more near to 6 millimeters on the right side. Maybe we'll have better sizing in the TO. And this is the last loop, so it's 5 chambers. It's not very clear, but we can see once again the VSD with the left to right shunt. So this was our evaluation. We had the medical surgical team discussion, and we decided to go for percutaneous closure. Well, this is just to ask, what about this case? Did you manage maybe in a different way in your centers? And if you had to go for CAT, which kind of technique would you use?
So, Olivier, you can explain the echo.
Yeah. So briefly, here it's a TEE view. So you could see the four-chamber view. So the left atrial cavity is in contact with the probe, for those who are not used. So you see the left ventricle in the middle of the sector. So when you assess a VSD, basically you have few things to check. First of all, the global assessment. So you have the biventricular function, systolic biventricular function, which is normal.
Yeah,
take time to always assess AV valve, just to be sure that you don't have any regurgitation before an intervention.
Okay.
As explained by Mark this morning, one of the major complications after this type of intervention is AV valve regurgitation. So here you could see that you don't have any tricuspid valve regurgitation, you have a trivalve mitral valve regurgitation. And so in four-chamber view, you could continue, you could just confirm that you don't have any atrial shunt. So you are at 0 and you could turn around your interatrial septum just to confirm that you have no shunt between both atria. And here you could see that you could easily see the VSD, the ventricular septal defect. So the 60-degree view is usually very comfortable to see it. So you see the aortic valve, you see the hole, which is anatomically in a perimembranous area. You see the left and the right coronary cusp. No regurgitation through the aortic valve in this view. We'll double check in long axis view. And the hole itself. So one of the key points when you assess a VSD is, first of all, the localization. So it's a perimembranous VSD. And the size. So you will use different frame to assess it. And you will assess the different diameter. So here it's a left diameter. And here it's not the ideal one. I will show you this is a right diameter. So with my colleague, we said that's between 6 and 8 millimeters, 8 millimeters on the right side. So the 60 or 45 degree the good one, and you will continue. And so we'll basically see it in long axis view. So here it's a 3-chamber view. When you have access to the full left ventricle,
Je peux reprendre les gants?
the LVOT, the aortic valve. So using the color, you will confirm that you don't have any aortic valve regurgitation. You have a trivalve, mitral valve regurgitation. The aortic valve hemodynamic is extremely important because we will use the left axis, so retrograde. And there is always a risk of contacts between wire or sheets with the valve. And here you could see that before the procedure, there is no regurgitation. And so again, you will move a little bit the probe, turn a little bit the probe clockwise to better see the VSD itself. Just here. And this view is very useful. This view is very useful to assess the distance between the hole and the aortic valve. So again, take your time, select the good frame as soon as you have one in which you are comfortable. For example, this one is pretty good. So you see the right coronary cusp, the distance, which is less than 3 millimeters. So it's pretty close. It's not a contraindication per se. I mean, even if it's pretty close, you could use different type of devices to close the hole. But it's important to know it because you will not oversize the device and more specifically the left disc to avoid any contact between the disc and the aortic valve. And so again, here you could see the hole. So this is the left diameter.
Can I make a comment? It's Mark here.
Hey, Mark. Yeah.
Sure.
I think you underestimate here distance to the aortic valve. Here you would say, so in the long axis, it's only 3 millimeters. However, can you go back to the short axis? There you will see that actually the VSD is just below the commissure, right? Now what you have to realize that in the tricuspid valve, just
Mark, sorry, can you speak on the micro, please? Because we don't hear you very well.
Can you speak louder?
Louder on the microphone
hear me now?
or near the computer. I don't know where.
So you were saying that in short axis,
Yes. If you go in, yes, there you see the relationship between the commissure and the VSD. Okay. And so what you may not forget is that the commissures come up exactly at the commissure. So that means the distance between the hole and the place that you have for the disc to be placed is much more than the long axis would suggest you, because they go up. Yeah. And it's very important. I mean, sometimes frequently a VSD is associated with an asymmetric aortic valve. So if the VSD has no relationship with the commissure or the commissure somewhere else, then you have less space. In this case, the VSD is just below the commissure, which means, as you know, that the cusps will be coming up all the way to the sinotubular junction. You have a pyramid of tissue above the VSD. And so you will be able to put the VSD between the cusps almost. Yeah, of course, you may not exaggerate, but it looks better than the long axis.
On the long axis.
Yeah.
Yes.
And when Mark says the cusp, just to be clear for everyone, this is the left and the right cusp.
There.
So,
yeah.
And the non-coronary cusp is far away of the VSD, of course.
Yeah, and so here you have to realize that the cusps are going up like, I mean, all the way, and you have distance over there. If you look in the long axis, And that is another thing that you have to realize in echo, the thickness of the slice, yeah? The long axis did suggest that the VSD and the right cusp were just next to each other. That is not true. There is distance, and that millimeter you will use to put the disc in between the two cusps. But of course, you may not exaggerate. But I think here probably you have enough space to put the disc without interfering with the cusps.
Yeah, it's a very important comment, Mark. You are right. We discussed about that yesterday, about some limitation by echo. You talk about kind of spatial resolution, even if it's not the spatial resolution, it's the elevation. So the fact that in one frame, we could see different type of structure. And you are right, sometimes we could either overestimated or underestimated the distance between two structures due to this inherent limitation. Maybe I could just finish the anatomical description in short axis view, because Mark said that in this view, you could better see the spatial relationship between the VSD and aortic valve cusp. And you could also see the relationship between the VSD and the tricuspid valve. So Mark this morning said that depending of your approach, but you could have a high risk of contacts between the device and the tricuspid valve apparatus. So basically cordae and papillary muscle. And here you could appreciate by echo why Mark says that this morning. So basically, as soon as you will see the device through the hole, the right disc will be directly almost in contact with the tricuspid valve. And so in order to anticipate this type of limitation or this type of complication, I will say, confirm that there is no aneurysm and no abnormal tricuspid valve apparatus, which is not the case here. So you don't see any tissue surrounded the hole. So you don't see any tricuspid valve tissue directly in contact with the hole. And I will say to me by echo, it's fine. Yeah.
Okay.
So Mark, we plan to implant a 10-8 MFO.
Just to go, we would like to introduce our guest today. He's coming from Peking, China, and so Dr. Pan. So Dr. Pan is with us because he's big experience of closing this kind of shunt under guidance echo. So we will try to close this one under his supervision, only on the echo guidance, TE or we will see. Yeah, okay. Can I let you introduce the case if you want? Yeah, the technical issue.
Okay. Good. So everybody, it's great pleasure to share the lab case with our colleague together. So the patient is suffering typical VSD. So today we just only echo. So we only puncture the femoral artery and advance the pigtail. We have cock the pigtail at 4 o'clock to get the curve is suitable to the VSD. And then we advance the wire and catheter together to pass the aortic arch and pass the aortic valve. And rotation get the catheter towards the VSD, and we get the wire past the VSD to the right ventricle and located the wire to the apex, and then we advance the sheath and can implant the occluder. That's the whole procedure. That's the plan. So we are ready.
Okay, I'm not sure that you can see the cut pigtail. Yeah, on the. Okay.
Okay, so let's go. Mark, do you have any comments?
About the sizing or something like this? Yeah.
No.
Dr. Pan and Zach said we take a 10-8 MFO. Yeah.
So that means that at the disc, sorry, the center of the device is 10 millimeter, right? And
Yeah.
the disc is going to be 14 millimeters, right?
Exactly.
Yeah. Okay. Which is rather big, but and the trick will
wire
be
and catheter go together.
to have the left sided disc nice
That's the wire.
adjacent
That's
to the
not the
septum.
catheter. Advance the catheter. Hold the wire and advance the catheter.
Okay, so
In fact,
Yeah.
we make
Yeah,
a
it's
marker on
wire,
we
yeah.
make a marker on the pigtail, yeah, to be sure that we will go on the ascending aorta. Yeah.
So now you can see the wire on the suprasternal view in the aortic arch, and we are advancing the catheter over the wire.
Yeah.
Okay, the wire, the caster is coming.
Yeah.
So now we can try to advance the wire, get the wire to pass the aortic arch.
Okay.
Yeah, advance,
Vas-y.
advance. Come on. Yeah, it passed. And advance the caster along the wire. Yeah, go ahead,
Okay.
Good. Show us the aortic arch, long axis.
So as you could see by echo, the transthoracic acoustic window is not ideal for this patient, but we'll try.
Long axis, yeah, right. Take the wire, yeah, take the wire out. Okay, good. And the rotation and advance the caster, get caster pass. When the valve open, it's better, echo is better than fluoroscopy because you know when the aortic valve is open. So when it open, you advance your caster, get it past the aortic valve to the left ventricle. Rotation a little too deep. Okay,
Okay.
good job. Okay, stop there.
Super.
Stop there. So now the view, echo view is totally different from TE. Now we only use a TTE. So the VSD is on the upside. Okay, rotation your caster, rotation, no color.
No color. Yeah.
Yeah, no color. Good. Rotation your caster,
I think we're fine, huh?
location
Maybe we
caster,
can
and
try
try. Yeah, good job.
advance.
Try to advance your wire. Try to advance your wire. Advance your wire. Good.
So we should see the wire in the right ventricle, either PA or the
Location
apex.
or always give the long axis view of the aortic artery.
So long axis, Olivier.
Sure. Yeah.
Yeah,
So for now, we did not pass through the hole.
good. Try the wire. Try
Okay.
advance the wire.
You said you were using a cutoff pigtail. At what angle did you cut it off? At 90 degrees or
4 o'clock,
120?
4 o'clock.
Yeah. At 4
4
o'clock.
o'clock. So 120 degrees something, yeah.
I don't know.
Yeah, it's not the good direction. No, it's in the aortic artery. Yeah, we have to try again to
No.
pass the aortic valve. Pull back the caster and rotation and try to advance the valve again. Good. Pull too deep, too deep. Pull back, too deep. Too deep. Firstly, take the wire out. No wire inside. Okay, good.
Okay.
Okay, good.
Yeah.
Rotation.
You're in the LVOT.
Rotation the caster, adjust the direction, rotation clockwise. Good, good job. Try the wire. Always give a long axis view of the aortic artery. No
Long
short
axis view?
Good,
Okay.
good job. Always long axis view. Yeah,
Oh,
rotation,
On est...
rotation.
no, clockwise.
No. You pull back too much. It's in the aortic. Yeah, good job. Okay, rotation. Okay, try the wire. Try the wire. Advance the wire.
Le guide, il est droit ou pas?
Haven't
No.
wire haven't arrived. Haven't arrived wire. Still
Enlève la couleur.
no color. We
Put the-
don't need
okay.
color now.
Put the color off. It's like this.
Yeah. Advance the wire and rotation. You can find. You have to identify the direction of the caster.
On arrête homogène, je pense que on est assez profond là.
C'est trop profond.
Too deep. No,
Deep.
too deep. Too deep.
Yeah.
Yeah.
Just a little past the
Mm.
aortic valve because the VSD is very high, very close to aortic valve.
If you prefer to switch by TEE, let me know, guys. Huh?
Okay, it's up to you.
Yeah,
Actually,
just to-
TTE is
just to
enough.
see.
It's up to you if
Yeah,
you
vas-y,
have.
passe en
Good.
entier, on voit mieux, parce que je vois pas grand-chose.
Right. So the advantage to be in the cath lab is to have both.
Long axis
So
view.
just for the guy.
Long axis, please.
Long axis?
Yeah.
Sure.
Yeah, long
Yeah.
axis view.
Great. Okay, so
Try to get cast the past.
so now we are still in the aorta.
Rotation and pull. Good. Advance. Rotation and advance. When the valve open, we advance the caster. Should pull back 2D, pull back a little, and try again. Yeah. Going down. Advance. Yeah.
Je suis passé là, non?
Okay. Can you show
Now,
us the
long
hole,
axis.
Olivier?
The whole, yeah. The whole is here.
Okay, okay. Okay, so please stay on. Yeah,
Good.
okay, good.
Go,
So
go
now
ahead.
we're almost
Heaven.
on contact
Go
with
ahead.
the shunt. Pousse là.
Le guide.
I think you are still in the ascending aorta, guys. I don't see.
Yeah,
Okay.
it's
Yeah.
going to
No,
the
no, no.
sickness. Pull back.
Yeah.
And rotation and advance.
Yeah, I see your tip.
Rotation, advance. Rotation counterclockwise. Good. Advance. When it open, advance. Heaven. It go to the sickness. Pull back. Pull back and try again. Pull back. Still too deep. Rotation counterclockwise. Yeah, almost. Just now, almost. Try again. Rotation clockwise. Good.
Yeah.
Good job. Okay, stop there and advance the wire. Advance the wire. Not too deep.
No,
Not too
in
deep.
the-
Just a little. Okay. Rotation the caster. Don't
Okay,
advance the caster too deep because the VSD is very high. Yeah. Advance the wire. It will be easier for echo to find the direction. Good. Advance the wire. Rotation. Okay, good. Advance the wire. Get the wire out of the caster.
Là, t'es
Good.
dans
The,
l'autre
the
sens.
direction.
Tu
The
tournes.
direction is
Ouais.
not good. You should
Là,
rotation.
là,
Good job.
okay,
Yeah.
Why?
Okay.
Advance the wire.
Okay.
Get the wire out. Okay. It's
Oh,
too
yeah.
deep. It's too deep. You should pull the whole system a little.
Retire un tout petit peu le cathéter.
Pull the whole
petit peu,
system a
Un
little.
petit peu.
Okay, not too much. Advance the wire.
Je suis sorti.
Non. Si? Ouais.
I think you are back in the ascending aorta, guys. I don't see you in the LVOT.
Due to the position of the VSD, the challenge is to get a good position to push the wire toward the right ventricle.
Yeah,
Good,
you are
good
back
job.
in the
Stop
LVOT.
there,
Good.
stop there. Advance the wire and pull back the whole system slowly. Too deep. Just a little.
Il sort pas, mon guide.
Rotation and advance the wire. Advance the wire. Where's the wire?
Impression
You are-
on my wire.
You are
Not
back
to
in the in the ascending
You
aorta,
lost
guys.
again.
Yeah.
You lost again. You lost again. Don't advance the wire.
So as Zach just said, you could see on this view that the VSD is extremely close to the aortic aorta. So as soon as
Too deep. Okay, good.
Keep this image, Olivier. It's very useful for us because we can
Too
see
deep.
that.
well,
deep,
well,
too
you are
deep,
very
too
deep, guys.
Too deep.
Yeah. This one, Zach?
Pull back
Yeah.
caster.
Yeah, that's
Too deep.
perfect. I think that the catheter
back,
is
caster,
very,
caster too
very
deep.
deep.
advance the wire, help you to pull back the caster. Otherwise, it will
Okay.
circuit reach the
Okay.
caudate. Okay. Advance your wire. Advance your wire. Get your wire out. Okay. Pull back the caster. Pull back the caster. No resistance, right?
Ouais, le guide là pour voir. Non, on est trop profond, hein, JB.
Ouais, voilà.
Ok.
Bon, tiens,
Donc,
prends le
non,
guide, toi.
You should advance the wire and
Montre-le.
Hein?
Montre le guide. Je pense qu'il est sorti là, tu vois.
Ouais,
Gros.
mais il faut qu'on voit où est le cathéter, hein.
Mais tu le vois pas.
advance the
Yeah.
wire.
Mais il
Use
faut
the
qu'on
wire
faire
to
le cathéter,
help.
alors.
Oui, attends, montre le guide. Voilà.
Okay. Use the wire to help.
Faut que tu
To
retires.
cast the entangle
Comprendre
with
ça.
the caudate.
So the catheter to me is very close to the aortic valve now.
Yes.
Non.
Advance the wire.
But the
Advance
wire
the
is
wire.
pretty deep.
Yeah,
It's
advance the
better.
wire. Advance the wire. Yeah, haven't
Yeah.
alive.
Yeah, the wire should be very close to the VSD now.
Non, ça a sauté. Ça a sauté.
Yeah, you are back in the ascending aorta, guys. You are back in the LVOT.
Pull back, too deep.
Yeah.
Still too deep. Pull back the caster a little, pull back. Okay, stop. And advance the wire.
C'est pareil.
Oui.
Là.
Okay. Good position, I think.
Yeah.
Try to rotate.
Yes. Have you guys
You are back
already
in the ascending
seen,
aorta.
have you seen the curl of the catheter? I mean, I've always seen the shaft, but I've never seen so far the curl of the catheter, let alone you have not demonstrated that the curl of the catheter is looking anterior, I mean, towards the VSD. And if, as long as you're not sure of that, I mean, you can fish for a long time. So is it possible,
So what-
once the catheter is through the valve into the left ventricle, to have a longitudinal view just of the catheter to be sure it's pointing towards the VSD? And then indeed,
Okay.
when you then,
So you advise us to pull back the wire and see the angle of the catheter to make sure that it is correctly directed, huh?
right.
Okay.
I mean, the difficulty of echo-guided procedures is the tip of the catheter. It's hard to see the tip of the catheter, and that's what it's all about. You need to know where the tip is.
Okay.
Okay.
Yeah. So you are back in the LVOT. So I think, correct me guys, but I think for you guys, the tip is pretty clear.
So we pull back the wire, huh? The only.
There is no wire.
Okay.
Okay.
Just here, advance the wire. Use the wire to help you to
Yeah, yeah.
enhance the echo
Yeah.
view.
But now
So-
the tip is looking opposite to the VSD. You have your
Yeah.
catheter and your tip is looking elsewhere.
Too deep. Pull back. Yeah, pull back. Pull back.
That's a
Pull
that's a
back.
correct
back.
orientation, yes.
Pull back.
Okay.
It's a good orientation. Pull back.
So the tip is-
You should
tip is
advance
there.
the wire. Otherwise, we will slide back quickly to the artery. Advance the wire. Average because the railway side is still there. When the wire is in the caster, the railway side disappear.
Yeah. Oh, very
Yeah,
close.
it's
Huh?
coming. Yeah. It's still high. Yeah. Pull back the whole system a
at the
little.
end
Yeah,
also.
advance the wire. Trying to advance the wire and rotation the caster a little to adjust the orientation and get the wire past. You pull the wire out.
Il est ressorti. Hein.
Ok. T'es repassé.
You are back in the LVOT.
Help you control the wire. Yeah, give me the wire. You rotation and pull. Yeah, right. Okay. Yeah, very close. Very close. And pull back. Pull back the whole system. Pull back a little.
Yeah. In, no? No?
No. Show us
So-
the
No, I think
long
we are
axis. Yeah.
back in the aorta.
Okay, sorry, guys.
This view is good also, huh, Olivier? Yeah, this angle.
It's
This one?
an
Yeah.
aortic artery.
Yeah, I think so. Huh?
Aortic artery.
So you could see the full catheter
Exactly.
and the orientation with the VSD, as Mark said. So we
Yeah,
just
it's
try
good.
to be really in front of the hole using your catheter. And as soon as you will be in front, the guide should enter into the VSD.
Caster too high. Caster advance.
I don't see your catheter anymore, guys.
Mm.
Did you pull back your catheter?
A little bit, I
No,
think.
no,
So.
no, stop there. Like show us the aortic arch. Aortic arch.
You did see the aortic arch?
Yeah, you
Ouais.
put just now you put back
Remonte
too
un peu
much.
comme on
So
voit
you
ici.
go to the bench.
Yeah.
Yeah.
Okay,
TTE,
okay.
TTE,
Yeah.
Aortic arch. Yeah.
Let's do that.
Mhm.
It's similar to fluoroscopy. Even if we use fluoroscopy, we also should advance the wire past. Aortic, no, wait a minute. Aortic arch. Yeah, show us the band. Where?
Classical trip. Okay, guys. See aortic arch?
Put it down. Put
Oh.
the caster down. Put the caster down. You should find the wire. Yeah, this is the wire. Wait a minute.
Okay.
Okay, it's done. Okay, advance the caster. Yeah, just now the caster go to the bench. Okay, good. Show us the long axis view.
Okay.
Maybe on T. Hein, Olivier?
What you prefer?
Ouais, vas-y,
Ah.
moi mieux quand même.
Yeah. T is better,
T?
hein,
All right.
for intracardiac structure.
Long axis. To show the valve and the aorta. Yeah.
Okay.
No, rotation, put back and rotation. You can go directly. Okay, good. Go ahead. Okay, go ahead.
Still ascending aorta.
Yeah. In contact with the valve.
Mhm.
Think you make a loop in the aorta, no?
Yeah, you are very close to the aortic valve now.
Mm. No.
Don't put back the caster too much.
Yeah.
Yeah, otherwise you will go to bench. Fine.
Mhm.
Go to the bench. Yeah, put back. No problem. No, just wait for me.
Yeah. I have a question for Dr. Pan. When,
Uh,
in order to know the
Can you shoot
orientation
the
of
branch?
your,
Sorry.
Mark has a question for you.
yeah, in
Go
order
ahead,
to know in order to know the orientation of your bend, do you use sometimes the outside markers from your catheter? So we know
Yes.
that there is a flare over there and a written message. I mean, the size of the catheter and things like that. Is the relationship good enough? I mean, if there is no torque, knowing where the outside hub is that good enough to tell you how the curve will going to be of your catheter?
Boom, boom, boom.
So it's actually for the orientation is very important. So before the procedure, we should check the location careful. Excuse me. I'm sorry. Shoot the TTE.
TT?
Now, yeah, we lose the wire, lose the biocaster. So according to the experience, we choose how much we should cut the pigtail. And this step is very important. We have to make sure the shape of the pigtail is suitable for the orifice of the VSD. So that's the key point. Another thing is that with the help of echo, we advance according to the working length. The working length, with the help of working length, we should know.
We are going to,
I have problem.
yeah, we're going to test with the Terimo.
With this wire,
Yeah,
Trumo?
just to cross the valve. Yeah.
Okay, good.
Easily.
Thank you, Trumo.
So we're gonna use a Terumo hydrophilic wire to know if
Mettons en long axe, Olivier.
Gax?
Il est à TO là.
ETO. Ouais.
Ok.
Un tout petit peu plus d'aorte si tu peux, ouais.
Ouais.
Ok. Zach, tu pousses le guide là, Terimo.
on est dans l'art ascendante là, non?
Ouais, vas-y, pousse-le, allez. Essayer de passer le guide.
No, it's very easy for the Trumo wire go to the branch. Yeah, going up. It's not going down. So we should use the curve of the pigtail and help you to get the wire past the aortic artery.
Voilà, on sait pas ce
Mets-toi
qu'on
dans
fait.
l'arche.
De toute façon, on sait pas ce qu'on fait.
Comme ça te va?
Non, ça me va, oui. Très bien, en fait. Ok.
Ce qu'on voit là, c'est le guide hein, dans l'art.
Ouais. Là, je pense que c'est ton cathéter. Ça, c'est ton cathéter. Je sais pas si c'est le type. J'ai du mal à voir
Le guide, ça.
l'ensemble. Ouais, le guide, pardon.
Vas-y,
En tous les cas, je le vois pas passer. I don't see your guide through the aortic valve, but your guide is in the aorta.
Je crois qu'on a fait une boucle. Hein. Okay, so now we see the wire in the ascending aorta.
Yeah.
Yeah.
Pretty mobile, so not easy to see it by
Advance
echo.
the caster.
Yeah, just here.
Along the wire.
Ok.
You see the guide? Yeah.
So far, the valve
Because
not being crossed.
the top of the caster is curved, so you cannot get the tumor wire past the aortic valve. So use the caster pass directly.
Ok.
Yeah, I see your guide in contact with the aortic valve. I think so.
Ok, ça c'est mon cathéter. So.
Mark, what kind of guide wire you you use for crossing the VSD usually?
We use Teramo, the 0.035, but you have different stiffnesses in that.
Yeah.
And so we use the rather soft one.
It is a soft one, yeah.
It is a soft one, yeah.
Yeah. But in fact, the difficulty is to see the orientation because an echo is not so easy.
Yeah.
Okay. I have the guide. I pull back the wire just with the catheter. You think it's
No, it's not.
no?
It's not.
No, I don't see your guide.
Too bad.
Here
Too
it's in
deep, too
contact
bad,
with the aortic
too
valve.
bad.
Yeah.
Okay. Too deep.
I see it in the
Too
LVOT.
deep.
LV. Okay.
Too deep.
Okay.
Just to see the cat, the orientation of the cat, Olivier. Okay.
Okay. So pull back.
Too deep.
Yeah.
It will entangle with the artery, with the caudate. So advance the wire to help the catheter to pull back.
Okay.
On est trop là
Mais
encore.
retire tout doigt.
Good, good, good. Rotation, 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 rotation. Okay, try the wire.
Doucement,
Try the
doucement.
wire.
On va perdre la position. Non, on n'est pas dans la bonne position. Ok. So,
Pull back.
ok, super, Olivier. Reste comme ça.
Ouais.
Pull.
Ok,
Yeah.
ok.
Okay, advance.
Là, là. Là, ah non, elle avait basculé.
Whoa, please.
Pousse, pousse, t'es dedans là. Mais dans l'autre sens. Faut que tu torques.
Should advance the wire. The wire is still alive.
Torque.
Wire is still far away.
Non, je regarde vers le haut là, c'est ça.
Ouais. Je regarde de l'autre côté. Ouais. Non.
Another key point
So-
is that for loscopy, it's easy to find for the Terumo wire, but for echo, it's not easy to find the Terumo wire. So just now the wire is better. So if you pass the VSD, echo can tell us whether the wire have passed.
Mm.
As my suggestion is that we change to the Cordis wire.
So your tip of your catheter to me is back to the...
Je suis pas sûr, Olivier.
Ouais.
Je pense qu'il y a moyen qu'on soit passé. Hein.
Ah ouais.
Pas là,
Let,
ouais.
let
Non,
me one
vas-y.
sec.
Yeah.
I think we are possibly in the right ventricle, meaning that
Yeah.
we pass through the shunt. Okay, so we can
Yeah, I
see the
confirm.
wire. Okay, in the RVOT, we also have PVCs showing that we
Yeah,
are
you can find the
probably
wire,
in
right?
the ventricle.
You can find the wire.
Okay,
Yeah.
so maybe we can advance.
Yeah,
cat-
advance more, advance the
catheter.
catheter, and then we change to the, okay, stop there. That's
Okay.
enough, that's enough.
So catheter
Yeah, it's passed.
is
Put back,
okay.
we change the wire, change
so
another
exchange
wire.
wire?
Yeah, change another wire, yeah. Because it's too short.
Yeah,
It's
yeah,
not
for sure.
enough for the
Il faut
delivery
enlever, il
system.
faut mettre le J. Hein.
Yeah.
Remets
Okay.
un peu de J, Sophie.
So Mark, can you do you agree that we have passed the VSD and that we are in good position? Can you see the images?
Yes, but I must say that the people in the audience didn't see the critical moment. And so there is the question, can you do it over again?
Okay.
That's the reason why we should use the Cordis wire. Cordis wire will be very clear and echo can guide, we adjust the direction.
Okay.
And don't worry, and in the afternoon, we have some presentation. We also have some record to show you the full record, to show you how
Thank
to
you.
pass. Yeah.
Thank you.
Mm.
T'as remis du J,
Show
J?
me the cat, Olivier.
Je pense que là, il faut
I-
pousser à fond.
I'm
That's
pulsing the wire.
Pousser à fond. Au pire, on va. If you can see
Then
the
you feel
PA, Olivier,
resistant. Then you feel resistant. Is
Sorry, guys.
okay. Good.
if you can see the PA and make sure that the guide wire is at least beyond the
It's okay.
pulmonary
It's
valve,
okay.
so that we
And-
can be sure that we have a good position. Okay.
Yeah.
Yeah.
Now you can
Yeah.
you can feel there. You can find there is no railway sign, meaning that the wire has passed. Okay.
Yeah.
And another suggestion is that if you can use TTE to show us for chamber, it will be more clear.
Okay. Well, for
Okay.
chamber,
For
Olivier.
chamber TTE.
So
Yeah, because it's
so
very
just-
close to the apex.
just about your question for PAs, I
Okay.
see your wire in the main PA. Yeah.
Okay.
Yeah.
Okay. So we can. Are you sure?
Just here.
Not so far. It's okay. Yeah.
Okay. So now we're gonna exchange for, or maybe just to make sure, Olivier, can you show us the four chamber view to
Four chamber
see
view.
whether the guide wire is
The good position is actually for the procedure. The good position is that we should locate the wire curve on the apex. It's not going up to the pulmonary artery. But anyway, if you go to the pulmonary artery, also no problem. We
Yeah.
open it and pull back. Also can catch. Okay.
I think that's
anyway.
while
Can see.
passing the sheath, maybe we're gonna fall in
down.
the apex
Yeah.
and then be able to deploy the device. Do you
Yeah,
agree?
Okay.
Okay.
Yes,
Okay.
thanks.
Good.
Okay,
Okay,
guys.
now we can
So
pull- yeah.
we're gonna pull back the catheter.
Tiens, Zach.
Yeah, pull back the caster and hold the wire.
And introduce.
Hold the wire.
Mhm.
Vas-y.
And wait a minute, we should mark how deep we have insert. Okay, you pull the caster, hold the wire and pull the caster out. Okay, good,
Okay.
good. So we mark again how deep we have insert the pigtail.
Okay.
So we know how deep we should insert the delivery system. You still can find the wire, right? You should hold, catch the wire.
We are very.
Okay, catch the wire.
Very
Okay.
far. Yeah.
We measure again. We can use hand. 1, 2, 3, 4.
Okay.
Okay. For finger.
Tu tiens le guide, hein, JB.
Yeah, you can take everything out.
Okay.
Okay, good.
Yeah.
Good job. And
So
get the
yeah,
sheet
can you measure it
Yeah.
here with your
yeah,
hand so
get
that
the-
we can
first we get the sheet out.
put a marker
Yeah,
on the
put
sheath?
marker on the sheet. And when you put the marker, you shoot 1, 2, 3, 4. Okay, it's here 4. You also can measure.
Un stylo.
You also
Yeah.
can measure from the other side. Okay, so it means that the marker should be here. Okay, good. Good job.
Okay.
So
So
guys,
Right.
just to let you know, in transthoracic echo, I do think that your guide is in the infundibulum, the RVOT, not directly in the MPA. Yeah. So you see here the,
It's okay. Yeah.
yeah, just to let you know.
For chamber view,
In transthoracic view,
on
you
va pas
mean?
monter la prothèse.
Hmm?
Faut qu'on monte la prothèse.
Elle est préparée.
Vas-y, Sophie.
Yeah. We can show you the preparation of the device.
Ouais.
I
La caméra au-dessus?
help you to hold. Advance. Good.
So
Go
let
ahead.
me know if you can see
Go ahead.
the preparation. So
Go
as
ahead.
you can see, the device has
And
two
can
discs,
echo shoe.
the left
Wait a minute,
one
wait a minute.
and the right
Can
one.
echo shoe. Go to bang.
So we're gonna
Show
screw the
T.
device
We
on
are
the
passing the
delivery
delivery system.
system
Show us.
All right.
from the
Wait for them. Wait for them.
aortic side,
Wait for them. Wait for them. Long axis view.
and then load it
Long axis, Olivier. Yes.
within the delivery
The five
system.
wire.
Okay.
Okay. Go ahead.
Okay.
Shoot the wire. Go ahead. Go ahead. Go ahead. The delivery system. Go ahead.
Attention, Sophie.
Go ahead. Haven't aligned. Yeah, we have passed, right? That's the good position is going down to the apex, okay?
Okay.
You haven't reached. You haven't reached.
Faut que tu avances encore, JB.
Okay,
Yes.
good,
Yes.
good job, right? That's good. It will
Okay.
be protect.
So Mark, can
But-
you see
If the VSD is
position of
very
the
small,
sheets?
don't do this, okay? I measure again.
Oui, on voit
The
le
marker
guide.
is there. You
Yeah.
haven't reached.
Comment
Can I
as-tu
still go
orienté le
Can you still
device?
go ahead?
Qui sera le côté gauche?
you should still advance. You haven't passed.
J'ai vissé le
You
côté gauche.
haven't passed.
Hein?
I think it's okay now. So far.
No, haven't. No, it's yeah. You
Now it's
just
done. Now
passed,
it's done.
but
Now it's done.
but it's not enough. Okay, be careful.
Okay.
I think
Okay.
we're fine, huh?
Another key point is that if the VSD is small, don't get the inner curve out. Okay, because the sheath is not easy to pass. Okay, advance.
Huh?
No. Okay, advance.
C'est quel
The
guide qui est
sheath
maintenant là?
haven't passed. Wait a minute. Let me see.
Olivier,
To
can
us
you,
the long side.
Sorry?
can you just try to follow the catheter from the
Yeah, wait a
aorta?
minute. Just
the
there.
apex.
Just there. I
I'm
want to
not
check.
sure that the sheath passed across the.
You haven't
shunt.
crossed. You haven't crossed. Your shoes touch. Wait a minute, just there. I want to test whether we have the railway side. If you can find the railway side in the right ventricle, it means that is okay. But if you cannot find, it means that you haven't passed.
T'as remis le dilatateur, JB?
Little bit. Push
Vas-y.
dilator.
Do you
It is
sometimes
difficult
use,
to know.
question to Dr. Pan, do you sometimes use bubble contrast to know exactly where the
Yes.
tip of your sheet is?
It was
Yeah.
exactly what I mind.
C'est très distal, hein, JB. Hein?
Ouais.
Uh,
I think
I
you are
think
very,
we're-
very
I think
distal.
we're fine,
Yeah, I think you are fine. Yeah, for me. Okay. I'm just pull
But-
back. Yeah, the
okay.
dilator.
So we're gonna pull back the dilator and
Make
leave
it-
the
make it
wire
again.
just in
Yeah,
case.
it's okay.
You haven't
Maybe
applied.
make
No,
a
no,
bubble
still far away.
contrast test
Still far
so
away.
that we can see, Olivier, if we inject the RV or not. Okay, Olivier?
Yeah. Right now, you want?
JB, t'es à fond, hein? Touche pas
Non.
plus.
On n'est pas arrivé au repère qu'on
Ouais,
avait noté,
mais
mais je pense que c'est.
On va faire un peu de contraste, laisse
Yeah.
le guide, ok?
Okay.
So we're gonna just,
Pull back the dilator. Yeah,
Okay, wait a minute.
let the wire. We're going to make contrast. Yeah.
Hold the wire. Be careful. Hold the wire. Be
contract.
careful. Hold the wire. I will catch the wire.
tiens,
Right?
tiens le guide. hein.
Je l'ai.
So Olivier, we're gonna inject.
So even if we
Some
measure
saline.
the pressure, we also should be careful if the delivery system just pass a little.
Okay.
Okay.
Yeah, RV.
Haven't.
So contrast in the RV.
Wait a minute. We still have to. Sometimes we have the problem. The delivery system just touch the VSD. It haven't passed enough. After you, if you inject something, you can find the bubble. But if you pull
No,
the
we-
wire out, it
We
will
are
go away.
on the apex.
Yeah. So
Yeah.
don't worry, we can do the test.
Yeah.
I teach you that. So Echo, can you show me the wire or the shadow on the right ventricle? Yeah, good. And we pull the wire out. Okay, the lock.
Yeah. I like to do the
Okay.
double test. Yeah.
We pull and we can find if the shadow. Wait a minute. Okay, if the wire shadow disappear, no freeze, real time, and you cannot find anything, it means that you haven't passed. If we pull, stop there, show us the view. Okay.
Well, I think we're fine. Huh?
Okay, it's fine.
Okay. So now we pull back the
Okay, we provide
wire.
one wire. Good job.
JB,
Okay.
Yeah.
Good.
peut-être. Ouais.
So you see here.
So
the
now we-
sheet,
Don't check.
without anything in it.
You should not this.
So now-
line.
We're gonna advance
Lock.
the
You should
device.
start and lock.
It's not possible. Yeah.
No, this
No,
one.
it's okay. Don't worry.
It's okay.
We used to do this. Yeah.
Oh,
Yeah,
you
the
use
catheter
different
should get
sheet.
the apex.
Use
huh?
different
Oh,
sheet.
Yeah, the tip. It,
Okay.
Yeah.
Right.
So the tip
We pull
of the
back.
of the
Yeah.
the delivery
Don't need
sheath
it.
is in the apex, right,
Yeah.
Olivier? Okay. Olivier?
What do you
Yeah.
think?
Sorry, Zach.
So
need this?
the tip of the delivery sheath is in the right ventricular apex, right?
Yeah, exactly.
Yeah.
That's
Okay,
what we
so we're
discussed.
gonna
Can see it just here.
with the right disc. Okay, and we expect to see the right disc
out.
at the apex. Maybe this view is good, huh? Maybe this
Yeah.
one, okay?
Okay.
And
How the
then we're
shape
gonna
get
pull
the
back
shape out.
the disk toward the VSD and then deploy the whole system.
Okay.
So if you can just keep this one, for us, it's perfect. It's a good one.
Okay.
And poor advance. When the railway side disappear, we can pull back the system a little because now the top of the delivery sheet is touch the wall or the right ventricle. Okay, you still can find the railway side, so we can advance. Advance. Okay, it's disappear. It's disappear. Okay, poor. Advance.
Something
back,
went
okay.
outside the.
Yeah,
I think we can
pull back
see
the whole
the disk.
system. Pull back the whole
Pull back.
system.
Pull back.
Pull back the whole system.
So we can see the right disk at the apex.
Yeah.
Okay.
Yeah.
So keep
I guess you won't see
pulling
it.
back.
Do you feel resistance? No resistance, or you
No
can feel
resistance.
no resistance poor.
Yeah.
You're
No, you
crushed
have
in
resistance.
something
You
else.
have resistance.
I think I see two discs, guys.
Okay.
discs.
Advance the
Okay.
good job.
Yeah, you agree.
That's good.
Pull back.
So
Pull
right,
back.
the right disk. Mark, can you see the images?
Put the whole system back. Put the whole system
Yeah,
back.
yeah,
Very
yes,
good.
we can see the right disc.
Poor.
Okay, the right disk is
Poor.
coming
Poor.
close to the
Yeah.
shunt.
No, haven't.
So now we're gonna
Poor the whole system. Okay. Short axis view. Stop there. Stop there. Short axis view.
Short like this.
axis.
Yeah.
okay.
Good.
So now you see the
Good
aorta.
position.
The right disc is in the right
Good
ventricle,
position. Yeah.
and so now
Just still pull back a little. That's close to the septum. Okay, good. Long axis view. No color. No color. No. Yeah. Long axis view.
Yeah.
Long axis view.
Long axis, yeah.
okay.
Okay. Still pull back a little. Pull back a little. Okay. Now you are ready to
Okay.
release.
To uncover, yeah.
Yeah. Hold
Okay.
the cable. Hold the cable.
Mm,
Pull. Good. Pull.
push,
Push.
push,
Push.
push.
Good job.
Okay.
Okay. It's done.
So now the disk is deployed
that's
in
hot.
the LVOT. We have to check, whether there's.
So there is a new AI in this setting of the full system will still the device attached to the catheter.
So
Which
now we have
means
to see
you
whether
can
this
Advance
regurgitation
more.
is due to the cable or
Advance the
to the
cable
device.
more. Yeah, advance the cable more to help the echo to test. Yeah,
Okay.
yeah,
So-
that's in a good position, right?
Yeah.
Advance the
view-
cable, you can shoot the good position, so echo can check again.
What's your feeling, Mark?
It looks very good. This view actually illustrates, if you look at the most cranial end of the left disc,
Just one
it almost looks like it's in the aorta, and actually it's in the region
Father.
between the commissures.
Okay, okay.
It's there, but you would
I-
think it is in the
I
aorta.
think we're fine. And
So here
what
in
is
this
your
view,
feeling with the regurgitation?
yeah, here in this view, short axis view, you could see that the regurgitation is mainly central. So it's probably more linked to the
But there is a cable, huh?
yeah, to the
It's
cable
inside the valve,
than
yeah.
the device itself.
Yeah.
To me, the device looks good. There is good motion for the leaflets of the aortic valve. I don't see any prolapse or abnormal motion. So to me, the left disc is in a good position. And again, the regurgitation is more due to the cable than the device itself.
And importantly, no residual shunt or paravalvular leak, meaning that the position, Olivier, is also
There is
good.
no.
Yeah. And one thing
Actually,
for if you think about the Mark's presentation this morning, always think to double check the tricuspid valve, to be sure that you don't attach any papillary muscle or chordae. And you could see that basically it's almost the same. There is a trivalve tricuspid regurgitation, but it's a detail. So to me, the aortic valve and the tricuspid valve looks good, and the device is well positioned and no residual shunts. Yeah.
Dr. Pan, what is your feeling?
That's good. I
Good
think it's
position?
okay. Yeah.
So if everyone is okay for releasing the device, I think we can proceed. Maybe GB,
Sorry?
can you confirm that
Yes.
all
Yeah.
good for you?
Yeah.
All
Yeah.
good, I think. Yeah. So,
Okay.
Mm.
Yeah.
okay.
So we're gonna release
Touch
the device.
No
Olivier,
color. When we release, no color.
put you
When
on
we
the,
release, no
no
color.
color
Thank you.
and
Shoot the
put on
occluder.
show on the occluder. Yeah, like this. Okay.
It will
Happy?
reposition. Buff. Good.
Okay.
Perfect. It's done. Okay. Good.
So released.
Get everything out. Get it out.
Maybe color Doppler.
So here you could appreciate the fact that the aortic valve looks perfectly fine. There is a tri-valve central regurgitation,
Mm.
but it's a detail. So the device itself looks good. Just one sec, you could see it there. I will turn around to be sure that there is no para-device leak, para-device chance. It looks good on this view. The mitral valve itself looks good as well. The same regurgitation as pre-intervention. So you will continue to double check the results using the short axis view. Whoop. So here, again, for the aortic valve looks
Okay.
fine. Central regurgitation, device is well positioned. Both discs are good.
Or something. No.
So to me, it's a very good result. Well done, guys.
Okay.
Yes. Yes, very
Congratulations,
nice.
guys.
GB.
Good job.
Can you-
Good job. Very good. So, which only echo to perform the procedure VSD is a little difficult for the new team. So, if you can perform this procedure, I believe that you
Happy?
also can perform the
you want
procedure
check
for
more?
ASD, for PDA, for pulmonary valve, aortic valve, even with mitral valve or implant stent for patient. Okay.
Thank you,
everybody.
Dr. Pan, huh?
Good job.
Good job.
Can we have
See you in few
First,
minutes to the
team
lyric.
have
Yeah.
a picture?